So COMBI-AD was a large randomized global phase 3 trial that took patients with nodal involvement, so stage 3 patients, and it was patients with stage 3A, B, and C in the AJCC 7th, and randomized them to either dabrafenib and trametinib as active therapy versus placebo. And treatment was conducted for a year. So over 800 patients were randomized, and the study actually had a very long follow-up. I can tell you that in the field we waited very patiently to see the results of that study. And it was really useful to see that because after a prolonged follow-up, and I believe it was over 2.5 years at the time of first reporting, the combination of dabrafenib and trametinib was highly effective. It decreased the risk of recurrence with a hazard ratio of 0.47, which is almost 53% reduction in the risk of relapse, and also had an improvement in overall survival as well. I was careful not to say significant because it had a really, kind of a low p-value. It was 0.000 something, but it hadn't hit the primary kind of level for significance for that study that was set originally by the statistical design. And then with the longer follow-up that was reported in JCO, it was interesting to see that based on a cure rate model, it was pretty clear that the combination is actually capable of curing patients, up to almost 17% of patients, which is really interesting to see. So we really do think that this is effective adjuvant therapy, and again, it's relatively tolerable. There were about 26% of patients that actually stopped treatment because of toxicity, and yet those patients still benefited. They were kind of analyzed in the intention to treat analysis, and they also derived the clinical benefit that was seen across the board. So, again, we think it's relatively safe, tolerable, and definitely effective therapy. So immunotherapy had already proven its ability to cure patients in the metastatic setting, and it made a lot of sense to test that in the adjuvant setting. So again, patients with stage 3 melanoma were randomized in a large phase 3 trial to either nivolumab or ipilimumab. Ipilimumab was used at a dose of 10 milligrams per kilogram, and I just want to highlight that because that's known to be a relatively toxic regimen. So when the study was designed, the idea was to use it in patients that were higher risk for recurrence. So it actually took patients that were 3B, 3C, and actually resected M1A as well that were treated on this study. And nivolumab proved to be actually superior to ipilimumab in terms of decreasing the risk of recurrence. The hazard ratio was 0.65, so it decreased the risk of recurrence by 35%. Which is fascinating because ipilimumab alone was actually effective against placebo when it was used in the EORTC trial. And ipilimumab alone had a hazard ratio of about 0.72, meaning that it decreased the risk of recurrence by 28%. And yet nivolumab actually was more effective and beat it with a hazard ratio of 0.65. I think that's really relevant because if you look at the rate of toxicities, ipilimumab at 10 milligrams per kilogram has a grade 3/4 toxicity rate upwards of 40%, whereas in nivolumab it was only 15%. And so again, it was a safer and definitely more effective therapy. And based on the results of that study, nivolumab was FDA approved for the treatment of patients with stage 3 melanoma in the adjuvant setting. The treatment, by the way, was for 1 year. So the International Neoadjuvant Melanoma Consortium is a consortium that was established in the last couple of years to really kind of define the way that we need to perform clinical trials in the neoadjuvant setting. And the idea was to really harmonize the study designs so that we treat patients with the kind of same duration of therapy before they go to surgery, that we treat them kind of in a relatively homogeneous way so that we can really understand the differences and the similarities between different trials. I take a step back and tell you that neoadjuvant therapy is appropriate for patients that present with bulky nodal disease. That's a population that is extremely high risk. If you take them to surgery alone, obviously surgery can be performed. People would go through completion lymph node dissections. However, after surgery, the risk of relapse is extremely high, upwards of 60, sometimes as high as 70%. And so the idea of using effective therapy that we now have at our disposal, like dabrafenib, trametinib, or BRAF inhibition, or immunotherapy with single or combination therapy, using it ahead of surgery kind of makes a lot of biological sense, both because you can kind of cytoreduce the tumor, decrease the size of the tumor, maybe improve the outcomes of surgery, but most importantly, biologically, especially in the case of immunotherapy, you may actually be able to induce a better, more sustained immune response if you treat when the tumor is in place. So that's kind of the concept behind doing neoadjuvant therapy. There were several clinical trials that were done at multiple institutions, mostly as single center clinical trials. For instance, we had performed 2 at the University of Texas MD Anderson Cancer Center. Our collaborators in Australia had performed a couple of trials, again with targeted and immunotherapy. Same thing in Europe. And so we all came together as a group to kind of, again, learn from each other, discuss best practices, and try to harmonize the way we design and analyze those trials. And what was really interesting is that we did find a lot of similarities between our trials, and then we decided that given the fact that most of them were kind of conducted with the same approach, or at least a similar approach, it was actually safe to consider putting all of the data together and pooling all of that data so that we can understand better the parameters of the patterns of response and the patterns of progression, and whether we can start kind of gaining more information with more patient numbers. And so the pooled analysis that was presented at the 2019 ASCO annual meeting was actually about 188 patients. I personally present this as basically this is the totality of all neoadjuvantly treated patients, in the world at this point. It included data from MD Anderson, included data from Europe, the NKI, and Australia. Also included data from the University of Pennsylvania, some data from Pittsburgh as well. So really kind of all of the studies that were ongoing with immunotherapy, anti-PD-1 and anti-CTLA-4 blockade, and again, targeted therapy. What was really interesting to see is that we had managed to induce a high rate of pathologic complete response. Now, what does that mean? That's a very important marker. It means that at the time of surgery, after treatment for sometimes 8 weeks, some of those studies were 12 weeks, at the time of surgery, there's actually no viable tumor in the tumor bed, right? And that's what's called a complete pathologic response, or path-CR. Path-CRs occurred actually at a pretty high rate. That was over 50%. Again, it kind of depends on the specific study. And then when we started looking at the patterns of recurrence, especially in the post-surgical space, so the relapse-free survival, it was really remarkable to see that patients that had a pathologic complete response had a great outcome, and they had a much lower rate of relapse. Now, patients that did not achieve a path-CR had a higher rate of relapse, which is, again, what you kind of would expect. It means that there was some viable tumor there. The interesting part is when we started kind of looking at the differences between targeted therapy versus immunotherapy, and remarkably, about 51 patients had complete path-CR with immunotherapy, and not a single one of them has recurred yet. So it's almost 100%, kind of relapse-free survival. There were recurrences with immunotherapy with patients that had no path-CR, but even that those patients still looked better than what you would expect for this population in the relapse-free survival. With targeted therapy, path-CR was associated with a really great relapse-free survival, but there were still some relapses even if you had achieved a path-CR. And if you looked at those curves, you would see that the patients that did not achieve a path-CR with targeted therapy are those patients that actually kind of did the worst in this pooled analysis. So altogether, I think it kind of points to the fact that neoadjuvant therapy is safe, is reasonable. It actually doesn't compromise the ability to do surgery, which is one of the concerns with neoadjuvant therapy. But most importantly, it actually can predict longer-term outcome.